but it's still got some gremlins. But maybe we'll get started, Mustafa. So I'm David Birnie. I am co-chairing this session. I work in Ottawa. I'm a cardiologist, but have been interested in cardiac sarcoidosis for many years. And my co-chair, I'll let my co-chair introduce himself.
Yeah, thanks, David. Mustafa Toma. I'm a heart failure and transplant cardiologist with special interest in cardiac sarcoidosis. I'm the director of the Sarcoidosis Clinic in Vancouver, British Columbia. And I'm very happy to be joining you guys as co-chair of this symposium. Maybe I'll let David introduce Peter, if that's okay.
Yeah, we'll go straight to our first speaker, who's Dr. Peter Sporn, is professor of medicine in the Division of Pulmonary and Critical Care Medicine, Northwestern. He's director of their multidisciplinary sarcoidosis program at Northwestern. His research focuses on clinical trials and pathophysiology of sarcoidosis. I've met Peter a number of times, and one of the things I've learned from him, he's a very talented jazz musician as well. So anyway, we look forward to your presentation just now. And again, apologies for the gremlins.
Well, thank you, David, and thank you, Mustafa, and really thank you to all of the organizers in Ottawa for inviting me. I'm a non-cardiologist, as you just heard, and I'm learning more and more cardiology all the time. So I appreciate the opportunity. Since these slides are not under my control and I have a lot of animation, I will just say next, but we're going to be saying next a lot because there's animation throughout. Anyway, I'm speaking really on behalf of my colleagues who are also investigators in this multi-center trial, PAPLAND, which we're going to talk about, which is funded by the Foundation for Sarcoidosis Research as part of the Clinical Studies Network under their auspices. So I'm speaking on behalf of all of my colleagues. Next. I don't think I have control. Yeah, okay. So these are my disclosures. And as I said, the FSR is the funder for the PAPLAND trial. And then these are my other disclosures, but none of them really pose conflicts with the content of today's talk. So next. By way of background, I think people in the audience are probably aware of the fact that the prevalence of clinically significant cardiac involvement in patients with sarcoidosis is really unknown. Next. In ACCESS, which was a multi-center NIH-funded observational trial funded by the NIH in the United States, conducted in the 1990s and published in 2001, the initial results, actually multiple papers resulted from that study. But in ACCESS, cardiac involvement was identified in 2.3% of over 700 patients enrolled at 10 pulmonary sarcoidosis specialty centers. Next. On the other hand, as many people are well aware, in autopsy studies, granulomas can be found in the myocardium in up to 25% of patients with sarcoidosis. Next. To date, however, no study has prospectively assessed a broad population of patients presenting with extracardiac sarcoidosis for cardiac involvement with the use of, among other things, advanced imaging modalities, including cardiac MRI and cardiac PET-CT. Next. So that is the background and the basis for the conceptualization of the PAPLAND study. The PAPLAND study is the melding of two protocols put forward in our network by Mohinthan Thalai at the Royal Papworth Hospital in the UK and Dan Culver at the Cleveland Clinic in the United States. It is a multi-center, two-arm prospective study conducted by the FSR, as I said, Clinical Studies Network. Next. And patients were recruited from 11 global sites, 2 in Europe and the others in the United States, into one of 2 study arms. Next. The first arm was the randomized screening arm to compare a standard versus an enhanced screening approach, and I'll describe those in a minute, for identification of cardiac involvement in patients with extracardiac sarcoidosis. Next. And the second was a chart screen arm to determine clinical features associated with subsequent Sorry about that. It looks like I was auto-muted by someone other than me. I don't know where my speaking left off, but you can read the slides. So as I was saying, the chart screen arm, the second portion of this study, was to determine clinical features associated with subsequent confirmation of cardiac sarcoidosis in patients with extracardiac sarcoidosis who at the time of initial evaluation were suspected on the basis of something to possibly have cardiac disease. Next. And so, yeah, so that's the focus of today's discussion, which is the chart screen arm and the data we generated. These are the study sites and the PIs at each of the study sites, as you can see. Next. So this is the study design. Patients with extracardiac sarcoidosis newly referred to one of the 11 centers for evaluation and management of their disease. Next. Who, if they had a prior diagnosis of cardiac sarcoidosis or previous advanced cardiac imaging, or if they were referred for suspicion of cardiac sarcoidosis, next, were excluded. On the other hand, if they had no prior diagnosis of cardiac sarcoidosis or previous advanced cardiac imaging, next, they underwent a careful cardiac history and 12-lead ECG. And if that was not suspicious for cardiac sarcoidosis, they were enrolled in the randomized screening arm and one-to-one randomized to either what we called standard screening, nothing evidence-based, but this is sort of historical approach, which included a history, as I said, in the 12-lead ECG, or enhanced screening, which added to that an echocardiogram with strain analysis and Holter monitor ambulatory ECG. Next. And those patients then were evaluated again at 12 months, again with the same history and additional studies according to what they were randomized to, and followed up again at 24 months. And in the interim, as well, if any events occurred that raised concern or suspicion for cardiac sarcoidosis, they were evaluated further according to the indications determined by the PIs, who are all experts in sarcoidosis and worked together, since the PIs were all pulmonary based, worked together with their cardiology colleagues at these specialty centers. On the other hand, if the history and ECG raised concern for possible cardiac sarcoidosis, they were next included in the chart screen arm, which is what we're going to talk about now. They underwent a workup according to the site investigators that included, next, a variety of studies, as you would expect, and as indicated by the clinical scenario. Again, pulmonologists working in concert with their cardiology colleagues, also experts in cardiac sarcoidosis at each of the institutions, to determine whether or not there was evidence for cardiac sarcoidosis based on HRS and WASOG criteria, which in the interest of time I will not go into, and a determination was made whether or not cardiac sarcoidosis was present. Next. So in total, 892 patients were enrolled. Next. 338 of these were enrolled between May of 2019 and October of 2022 in the randomized screening arm, and 554 were enrolled in the chart screen arm up through December of 2024. I'm going to talk about 499 of those 544. Here you can see the demographics and some of the associated comorbid conditions. The average age was 54. About half were men and half women. 75% were white. And you can see some of the major comorbidities related to cardiovascular disease, hypertension, lipidemia, hyperlipidemia, diabetes, and tobacco use. Next. And some of the additional diagnostic testing that occurred in patients who were further evaluated were additional ECGs, an echocardiogram, Holter monitor, cardiac MR, and cardiac PET-CT. Other studies as well, but these are the major studies, and you can see the frequency with which these were employed in the additional evaluation. Next. And other tests, as I said, were obtained, and those included tests for ischemia, including left and right heart cath, angiography, chest CT, PFTs, etc., based on the expertise of the investigators. Okay, so the final determination of cardiac sarcoidosis. We confirmed the diagnosis of cardiac sarcoidosis in 21.4% of patients in the chart screen arm, 107 out of 499, excluded the diagnosis of cardiac sarcoidosis in 67%, and the diagnosis remained uncertain in just over 11%. Next. So in the randomized screening arm, which is not the focus of today, but I'm going to tell you about these results, standard screening identified only 1 out of 170 patients with cardiac sarcoidosis, enhanced screening 2 out of 168 for 3 patients in the randomized screening arm. Next. Such that 97% of the confirmed cardiac sarcoidosis cases were identified in the chart screen arm. That is, among those patients who on initial evaluation there was some suspicion based on the careful cardiac history or the ECG that cardiac disease might be involved. Next. And so cardiac sarcoidosis was confirmed overall in 13.1%, or 110 out of 837 patients in the combined chart screen arm and the randomized screening arms. And this is a 6-fold higher prevalence of cardiac sarcoidosis or cardiac involvement than was identified in the ACCESS study, which I mentioned earlier. Next. Some of the features significantly associated with confirmed cardiac sarcoidosis included abnormalities on transthoracic echocardiogram, an elevation in the serum proBNP, elevation of serum troponin, bundle branch block other than an isolated right bundle branch block, and systemic hypertension. Next. Interestingly, features not significantly associated with confirmed cardiac sarcoidosis included a history of any palpitations, a history of daily palpitations, chest pain, syncope or pre-syncope, and a point on that, if a patient presented with syncope, most likely their first evaluation went through another path. They probably were seen by a cardiologist, and that diagnosis might have been pursued outside the context of patients enrolled in this trial. Interestingly, dyspnea, could we go back? Dyspnea deemed out of proportion to the chest X-ray and PFT findings was more common when we excluded cardiac sarcoidosis than when we confirmed it. And also, Holter monitor abnormalities were not significantly different. Next. So to conclude, PAPLAND is the largest study that has evaluated clinical features associated with a prospectively determined diagnosis of cardiac sarcoidosis reported to date, almost 900 patients. Next. Among those in the chart screen arm, where there was initial clinical suspicion of cardiac disease, cardiac sarcoidosis was confirmed in 21% of our patients. Next. 97% of the confirmed cardiac sarcoidosis cases were identified in the chart screen arm compared to only just under 3% of cases in the randomized screening arm. Next. Overall, we confirmed cardiac sarcoidosis in 13.1% of patients in both study arms. Next. And features associated with the final diagnosis of cardiac sarcoidosis included an abnormal echocardiogram, an elevated BNP, elevated troponin, bundle branch block other than an isolated right bundle, and a history of systemic hypertension. Next. And finally, the entire 554 patient chart screen cohort is being analyzed We are actually writing up the results at this time for submission for publication. And my colleagues are working on a predictive model that we might apply to our patients based on these results. Thank you very much, and I'm happy to entertain questions when that's going to be appropriate, either now or after all of the presenters. I'm not sure.
Yeah, no, we're going to do it after all the presenters, Peter. But yeah, so if everybody could hold their questions, you can start putting them in the chat if you want. But otherwise, do you have time to wait with us, Peter, to the end?
I'm sorry, what's that?
Do you have time to wait until?
Yeah, of course.
Perfect. In that case,
can I just ask a question? Are we going to do that before the case studies or after the case studies?
I was going to do it after the case studies.
Okay, I may leave and come back briefly later on because I do have something else. I have conflict, but I'll be back.
Okay, wonderful.
I'm going to be on now anyway. Thank you.
Yeah, and again, apologies. Juan, I'm not going to destroy your name by trying to pronounce it, but are you able now to present? Because I managed to change. Yes. I managed to change your status, so you should be able to share screen if that's okay, and then I will introduce you in just a moment.
Hope it's working.
Yeah, it's perfect. So our next speaker is from the UK. I don't have your bio, but I know a bit about you, Juan. I've been following your work for a couple of years now. You know, for a long time now, there's been a gap in cardiac sarcoidosis clinical research in that we've never had a cardiac sarcoidosis specific quality of life tool. We've had a number of sarcoidosis quality of life tools for some years now, but we've never had a cardiac sarcoidosis quality of life tool. So I was just very delighted to see Juan start work on this. He's a clinical research fellow. He's an advanced clinical practitioner in the UK. Maybe you could add one or two more things about yourself before you get going as well.
Yeah, no, thank you very much, David, for the invite. It's a great honor to be here. I'm usually attending this conference in the other side, on the background listening. So it's great to be presenting today this work. So my name is Juan. I'm a clinical research fellow now at King's College London. I'm also a registered nurse working as an advanced clinical practitioner nurse at Barts Health in London. And I have some research roles between Royal Papal Hospital and Queen Mary in England as well. So today I'm going to be presenting on quality of life in cardiac sarcoidosis. I don't have any conflict of interest apart of being funded by the Foundation for Sarcoidosis Research for the next 18 months to continue the work that I've been doing. So I will start today by saying that in cardiac sarcoidosis, there's probably, well, in sarcoidosis in general, there are more questions than answers. And I think it's important to know that we're still learning a lot, as we've seen on the PAPLAND study and the new studies that are still ongoing. But I'll put some reflections at the end of my presentation, and hopefully we can go on the discussions. Today, in this presentation, I'll focus on the background. I'll do a brief summary of a systematic review that was conducted a couple of years ago.
Wait, let's see what she said.
And an overview of the development of the cards.
I want you, if you wouldn't mind covering my 2 to 3 session with the student today. I'm unable to make it.
Thank you. So I'll present the development and the validation state of the CARD-SAT questionnaire, and I'll end with some conclusions and implications for clinical practice. I don't think if you're here, I need to define too much of what is cardiac sarcoidosis, but I want to add on saying that sarcoidosis and the burden of living with sarcoidosis is normally associated with a chronic condition involving physical, functional, social limitations, and emotional distress. In addition, for patients with cardiac involvement, they may experience more concerns and due to the cardiac symptoms associated with an acute condition. And when we consider indications for sarcoidosis treatment, there are two rules. One is treat to avoid danger, or the second will be treat to improve quality of life. But how can we measure quality of life if we don't have the right tools? So there are 3 existing questionnaires specifically for sarcoidosis that have been developed in the last 15, 20 years. They have been focusing on lungs, skin and eyes involvement, but they're missing cardiac specific items. And on the right-hand side of my slide, you can see some cardiac specific questionnaires that could cover potential manifestations of cardiac sarcoidosis patients, but there will be missing items for sarcoidosis care that are likely to impact the quality of life phenomenon, like multisystemic manifestations or immunosuppressant therapies. And we know that health-related quality of life is the main priority for people living with sarcoidosis, and the WASOC and the ESC recommended the inclusion of quality of life in research and clinical practice. So the first component of my doctoral work was to conduct this systematic review that is open access, and I left this QR code for those that want to look for more details later on. But I'll try to go through the main points. I won't spend too much time on the methodology. This was all registered in Prospero, and you can look into the paper. But I want to emphasize that we look into all the studies that had quality of life as a primary or secondary outcome with adult patients with cardiac sarcoidosis. And we include many supplementary search strategies to try to capture any potential study that was out there. We used Rayan for the study selection. We didn't exclude any study on quality assessment, but we used the CASP checklist to assess the quality and the risk of bias. I want to show you the PRISM flow diagram to emphasize the importance of the supplementary searches when you conduct a search on this kind of searches for cardiac sarcoidosis. It's important to do these supplementary searches. And as you may expect it, because of the nature of the existing literature, there was a lot of can't tell and yellow boxes that you can see on this CASP checklist. I appreciate this is a busy table, but I'll try to summarize it for you. So the result of this systematic review, there were 11 studies that included cardiac sarcoidosis patients, but none of them reported specifically health-related quality of life scores for patients with cardiac involvement. Overall, there were 5,300 sarcoidosis participants with almost 800 patients that had cardiac sarcoidosis, ranging between 2% to 22% in these studies. But only one of them had longitudinal data. So when we are assessing quality of life, we only have one snapshot of what was the quality of life. I don't have enough time to tell you everything about the different potential factors that were identified in these studies, but you can look into the tables in the paper, but I have included this illustration for those in clinic that may have cardiac sarcoidosis patients and can look into these potential sociodemographic, symptom-specific, or therapy-related factors that could contribute to living with cardiac sarcoidosis. The key messages on this systematic review was that the sarcoidosis studies didn't incorporate stratified scores for cardiac sarcoidosis involvement, which is limiting our capacity to understand the real impact on those with cardiac involvement. The development of cardiac sarcoidosis specific tools will be a great advance, and having longitudinal and multi-center studies assessing quality of life outcomes in cardiac sarcoidosis cohorts will benefit the field. So the next step of my PhD work was to conduct this first and develop this first specific tool for quality of life. And I use a sequential exploratory mixed method in a multi-center cohort study. I consider a clinimetric theory, which considers multiple attributes within a single index. and this constructed with emphasis on what patients and clinicians consider to be important. The legibility were adult patients with at least probable or highly probable based on the WASO criteria. This diagram illustrates a simplified version of the McMaster framework for evaluative instruments, including the COSMIN recommendations for psychometric properties. But I will focus presenting the development steps 1, 2, and 3. And I want to emphasize the critical involvement of the 5 patients from my public and patient involvement group that were supported by Sarcoidosis UK. The first step was item generation and included 5 sources to combine quantitative and qualitative components. If we're starting at the top and moving clockwise, the first one is theory and research and included sarcoidosis and cardiology conceptual models. The second step was the systematic review, which I already told you about. And the third source was 9 qualitative semi-structured interviews using thematic analysis and saturation to identify relevant concepts. Similarly, I conducted clinical observations in the 2 sites taking part, Barts Health and Royal Papworth, and I included the opinion from experts, including the PPI advisors and contributions from a multidisciplinary clinical expert panel. All of this was triangulated using simultaneous triangulation. And an example of this triangulation is in this slide. So if you're looking into the 4 major themes emerging from the clinical observations, these are in the top brown box, compared to the 8 major themes emerging from the interviews at the bottom of the screen. You can see how this triangulation took shape and was taking part with this software in vivo. So on the starting on the left, you could see a list of codes emerging themes, and in the center of the image is very small, but you can see a tree of themes coming up and connecting the different themes emerging on the literature and the fields that we were conducting from the interviews and observations. And on the right, these colors are corresponding to the relevant concepts from the interviews that were showing on the bottom of the screen. The second step were item formatting, and it was guided by the PPI advisors. We aiming to have simple and comprehensive sentences, considering a 2 weeks recall period and a 7-point Likert scale. The third step was item reduction, and it aimed to remove the duplicates, and it was guided by the panel with 26 cardiac sarcoidosis experts. So these experts included international representation from patients and clinicians. And initially, they scored 111 items from the preliminary list, which was reduced after a consensus meeting to a pilot version with 61 items. These boxes represent the 6 preliminary domains for pilot testing. And an innovative approach for the CARSAC tool was to format the first item on each of the sections as a potential lead item. So if successful during the validation process, this approach will help to generate a patient-reported outcome that can be dynamic and reduce the burden on patients with minimal or no impact on health-related quality of life. Moving to the validation and the field testing, this part will determine the reliability, validity, and responsiveness of the new tool. 5 time points were included to capture longitudinal data, comparing the CARSAC against validated prompts. And additionally, the psychometric properties of the new tool will be explored using graph analysis and item response theory. The recruitment was successful, and we over-recruited to the initial target with 131 consented participants. And I can tell you the field testing is ongoing, but most of the participants have been reaching the final follow-up points, and the benchmark is the 70% in a patient-reported outcome study. So for the 3 months, 6 months, and 12 months follow-up, we over the target for being good quality in terms of retention and completion rates. One of the major concerns was about the length of the questionnaire and the 61 items for the pilot and the field testing. And for those 117 participants that have done the baseline, we asked them to assess if this was difficult to complete. And it was reassuring to see that over 3/4 of the participants disagree. So only 11% thought that this was difficult going through 11 items. So even the lengthy version with 61 items is still considered and is not difficult for those living with sarcoidosis. I can share some of the results from the baseline that were reported by the different patient-reported outcomes, not the CARSARC. And something very interesting was that females in all the domains on the sarcoidosis-specific domains are scoring lower than males. And this is the same case if we look to the genetic-specific, the genetic tools for quality of life, or the fatigue assessment scales, or the HATs for anxiety and depression. So this is an interesting finding to consider when you see patients in clinic. Then we need to explore further, but it's an interesting finding so far on this recruited cohort. The next step for the validation will be to complete this field testing, which should be completed before the summer, to translate to different languages and to do a cultural adaptation. And I'm very pleased to say that this has been supported by the Foundation for Sarcoidosis Research with an early career award that started in the summer 25, and it will continue for the next 18 months to collaborate with the Cleveland Clinic and get an international group of patients and do this early validation internationally. So in conclusion, for the CARSARC, there was a robust methodology combined with active PPI engagement to develop the first disease-specific quality of life tool for cardiac sarcoidosis. The inputs from the PPI advisors and the multidisciplinary experts were essential to enhance the content validity. And we think that the CARSARC has the potential to influence clinical decisions in routine practice, support research, and provide a relevant resource for policy and commissions in health economics. I promised at the beginning of the talk that I'll do some reflections. So very quickly, I just want to say that we need to, as a community, we need to try to work together into measuring how, in different parts of the journey, how frequent we need to measure quality of life. It could be different and different stages of the journey. When is it time to calibrate all these tools that were developed 15, 20 years ago, considering all the changes in the field in the last years and the treatment and management options? And we need to think of the disease-specific and the genetic tools, how we do combine them to be successfully in trials and clinical practice. I just want to end up acknowledging FSR, NIHR, and the host institutions for this work. And thank you very much for your attention. I'm very happy to stay and discuss more at the end of the presentation.
Thank you so much, Juan. What a wonderful presentation and such exciting work that you're doing. And obviously the Foundation Sarcoidosis is great to support you in this work and endeavor. So we look forward to more from you, and we'll do some questions at the end. So thank you. Our next speaker is Dr. Eliot Peyster, who I believe will not be joining us live, but there's a pre-recorded presentation that will be shown. He is an assistant professor of medicine at the Perelman School of Medicine at the University of Pennsylvania, and his research interest focuses on the use of advanced computational methods and spatial biological concepts to yield precision medicine breakthroughs. He's focusing on multimodal data integration, combining digital pathology analysis and other streams to develop novel diagnostic and prognostic platforms, including performing histoclinical profiling to predict transplant outcomes, but also performing high-plex spatial proteomics to uncover disease mechanisms in cardiac sarcoidosis. So very intriguing work, and looking forward to this presentation.
Greetings from Brisbane, Australia, where it's currently 3 in the morning and 26 degrees outside. It's a pleasure to have this opportunity to speak to you all today, even if it is remotely and slightly tape delayed. Over the next 15 minutes, I'll take you on a journey beyond the granuloma, sharing how spatial omics technologies can illuminate the complex biology of sarcoidosis. To set the stage, let's first review why CS is such a difficult disease to study and to diagnose. Cardiac sarcoidosis often represents a clinical blind spot for us. By that I mean it's a disease that we know is out there. We can get these fleeting glimpses of it, but our current tools just don't allow us to see it clearly or consistently. Clinically, while only about 5% of sarcoid patients receive a formal diagnosis, autopsy and imaging studies suggest that up to a quarter have cardiac involvement. Presentations span a wide spectrum from asymptomatic to sudden cardiac death, and too often diagnoses are only made after a life-changing event has occurred. In practice, conventional diagnostics fall short in this disease. The diagnostic gold standard, endomyocardial biopsy, is notoriously insensitive, detecting less than 20% of cases due to the patchy nature of granulomatous involvement. Imaging modalities, including MRI and PET, improve sensitivity but often lack specificity, particularly when extracardiac disease is absent. Because of these issues, current guideline-directed diagnostic frameworks are complex and convoluted, relying on varying combinations of circumstantial evidence and pretty complex flowcharts. Taken together, these factors create a pressing need for new approaches which can enhance our knowledge of the disease, and through that knowledge, unlock new avenues to improve the timeliness and accuracy of the diagnoses we give patients. Adding to these diagnostic challenges is the fact that there are no faithful animal models of cardiac sarcoidosis, which limits our ability to perform deeper mechanistic studies that might uncover new diagnostic or therapeutic paradigms. While I know that other speakers will address this topic in more detail, the current reality is that without reliable animal models of CS, human cardiac tissue is our only option to study sarcoidosis biology. Unfortunately, most available human CS tissues are archival, formalin-fixed, and limited in quantity. And these facts make it challenging, if not impossible, to utilize the traditional molecular omics approaches we rely on in 21st century biomedical science. Fortunately, emerging spatial biology platforms are now increasingly available to researchers. And these technologies are uniquely suited to overcoming the challenges of sarcoidosis. By visualizing protein and RNA expression directly on routine archival histology sections, we can now interrogate the molecular environment of specific tissue regions, granulomas, surrounding parenchyma, and more, while maintaining spatial relationships and preserving precious samples. This sets the stage for us to look more deeply into CS biology than was ever previously possible. The first major study in this domain was published in 2022 by the team out of WashU in St. Louis and provided a crucial foundation for using spatial biology technology in CS. Using nanostring geomics spatial transcriptomics along with single nuke RNA sequencing, they studied the granulomas in CS and myocarditis, identifying high HLA-DR expression, an enriched population of Cytal3 and GPNMB positive cells, and widespread mTOR pathway activation. Interestingly, the increased HLA-DR expression in population of GPNMB positive giant cells appeared to be a unique feature of CS, differentiating it from other forms of myocardial inflammation and myocarditis. This study was an important step forward for CS research, elegantly demonstrating that the cellular organization within granulomas is complex and perhaps unique. However, this study only focused on the granuloma lesions themselves. The surrounding myocardium was not explored in depth, and comparisons to other disease entities were pretty limited to samples from only a few patients. Inspired by this previous proof of concept work, and with the goal of addressing the many unmet needs that still exist in CS, we're now going to turn our attention to my team's recent efforts, where we expand the scale, the scope, and the diversity of spatial analyses to extend our knowledge of sarcoidosis beyond the granuloma. We assembled a cardiac tissue cohort of 64 patients, 39 with CS and 25 diverse controls. The CS tissues were comprised of both earlier stage tissues from biopsies at the time of CS diagnosis and advanced stage tissues from cardiac explants at the time of cardiac transplant. The diverse control cohort included non-ischemic cardiomyopathies, hypertrophic cardiomyopathies, ARVC cases, myocarditis cases, and organ donors who had suffered sudden cardiac death, each of which share some phenotypic overlap with CS. Using the nanostring geomics instrument, we performed spatial proteomics profiling of 80 immunologic, fibrotic, and proliferative biomarkers. And as a departure from the study from the previous slide, we focused on analyzing both granuloma-containing and non-granuloma-containing tissue regions. Specifically, we studied granuloma regions, including multiple granulomas from the same individuals, perigranuloma regions, defined as cardiac parenchyma tissue within 300 microns of a granuloma, and granuloma remote regions, defined as cardiac parenchyma at least 500 microns from any visible granuloma. After selecting our regions of interest, we performed digital image segmentation, which enabled us to generate separate proteomic profiles from the myocytes, from the stromal cells, and from vessels within each region. This multi-layered approach allowed us to capture both immune-specific signals and general parenchymal remodeling and inflammation response patterns, and to do so with tissue type-specific levels of detail. When we looked at protein abundance across granulomas, one clear theme emerged, and that was heterogeneity. Most biomarkers in our protein panel showed greater variance between granuloma ROIs than between the granuloma-free parenchymal ROIs. This was somewhat surprising to us, since the parenchymal ROIs are derived from very biologically diverse regions, which come from both failing and non-failing hearts with widely varying ejection fractions, and which have varying degrees of inflammatory cell infiltrates and varied proportions of stromal and myocyte cells. Even more interesting, granuloma heterogeneity wasn't just observed between patients. Even within a single heart, the intra-patient granuloma heterogeneity could be as great as the inter-patient heterogeneity. These findings have important implications for future studies. If granulomas are this diverse, then granuloma profiling data from small tissue cohorts might paint a misleading picture for us as researchers. To put it more bluntly, we should all be more cautious about overstating our findings unless we have assembled sufficiently large and diverse cohorts to look at. Moving on from granulomas, we're now going to turn our attention to the primary task of today's talk, investigating CS biology beyond the classical lesions that define this disease. One of the first questions we asked in our cohort was whether myocardial biology changes as disease progresses. In other words, whether there were differences between earlier stage biopsy samples and later stage explant samples. Perhaps unsurprisingly, we observed numerous stage-dependent changes in the parenchyma of CS tissue, which shed new light on the burnt out or late fibrotic phase of CS we often talk about in clinical practice. The cardiomyocytes of advanced stage CS show a pro-apoptotic shift with increased BIM, decreased BCL-XL, and reduced metabolic activity. In addition, the myocytes are less immunologically primed in late-stage CS, with markers like HLA-DR, PDL1 and 2, and STING decreasing in abundance. In the stromal compartment, there's evidence of increased fibroblast activation and differentiation, with more FAP-alpha and smooth muscle actin abundance. And from an immune cell phenotype perspective, advanced CS demonstrates an overall more quiescent inflammatory state, with effector T-cell and macrophage markers decreasing, while regulatory T-cell and checkpoint markers like FOXP3, PD1, and TIM3 all increasing, findings which are fairly suggestive of an immune exhaustion state in late-stage CS. Here in this slide, we're going to shift our focus from time to space. In the previous slide, we discussed changes in CS biology over time, describing a temporal gradient in protein abundance as the disease progresses. Here, the question is spatial gradients. In other words, does biology change across the cardiac parenchyma as a function of distance from nodes of CS inflammation? To set this up, we first compared inflammation-positive and inflammation-negative parenchymal regions from CS patients. These inflammation-positive regions contain histologically visible immune cell infiltrates, even though they did not contain any characteristic CS granulomas. And as expected, we found numerous significant differences between myocardium with and without these histologic infiltrates, including significant differences in basically every major immune lineage marker. When we next examined just the histologically bland, inflammation-free ROIs in our cohort, comparing perigranuloma parenchyma to granuloma remote parenchyma, we continue to see numerous differentially abundant proteins. Interestingly, nearly 70% of the proteins with significant differences between perigranuloma and granuloma remote regions were also significantly different when we looked at inflammation positive and inflammation negative tissue regions. However, these overlapping proteins were not the major immune lineage markers. Instead, they're more subtle markers of immune activity that wouldn't be apparent on an H&E histology slide, such as increased MHC molecules, long-lasting immune sentinels like dendritic cells and memory T cells, as well as checkpoint molecules and proteins indicative of stromal remodeling. This tells us that CS imprints a subtle but measurable spatial gradient within otherwise normal and histologically bland-appearing heart tissue, a concept that reframes how we think about this disease beyond the granuloma. Having shown that CS induces these distance-dependent, subtle biological changes in the heart, even in these histologically bland myocardial regions, the next question is whether this gradient extends all the way to our diverse control heart tissue samples. In other words, to tell whether even really remote regions in a CS patient look fundamentally different than other heart failure patients who don't have CS. To formally test this, we applied ordinal analyses across tissue rings moving outward from granulomas. These analyses confirmed a clear gradient. Proteins enriched closer to granulomas include immune modulators like FOXP3, CD25, TIM3, VISTA, PD1, as well as markers of stress-activated myocardium like HLA-DR, CD40, CD44, and CD34. In contrast, several immune cell types, including CD56 and CD163, showed reduced abundance near granulomas relative to more distant tissue, and in particular relative to the control tissue, which was higher than any of the CS regions for those markers. Next, we performed a group-wise analysis comparing only our granuloma remote CS tissue regions to control hearts, and once again we found striking differences in protein abundance. This is even when the focus of this analysis is on CS tissue regions which are furthest removed from any overt CS inflammation. Taken together, these results demonstrate that CS imposes not only a distance-dependent, but also an organ-wide biological effect, which makes CS myocardium look different from controls even when no granulomas are present in the surrounding area. And these results naturally led us to ask, can we leverage these hidden protein signatures that seem to be myocardium-wide to identify CS, even when examining histologically bland granuloma remote regions? To test this, we built classification models to distinguish between granuloma remote CS regions and control regions. Our final model incorporated 7 tissue biomarkers: HLA-DR, FOXP3, CD25, CD127, CD8, CD56, and CD34. The overall predictive performance of our models was surprisingly good, maybe almost too good. At the ROI level, at the region level, the model achieved 96% accuracy and an AUC of 0.99 on a held-out test validation set. At the patient level, when we aggregated the predictive probabilities of all 3 to 5 regions of interest sampled from each patient, and this 3 to 5 regions per patient is a number which was designed to sort of simulate biopsy sampling, which typically involves grabbing 3 to 5 pieces of tissue. Our model achieved perfect patient-level discrimination between CS and control patients. In our opinion, this is a translationally valuable result. In clinical practice, the biggest weakness of biopsy is sampling error. A 1 millimeter or 2 millimeter biopsy sample can easily miss a granuloma and be deemed diagnostically negative. Our granuloma remote regions, defined by being at least 500 microns to 1 millimeter away from any granulomas, are an experimental analog of exactly that problem, showing that these regions can still harbor strong predictive signals even when they're far removed from the node of biological activity. And thus, they really do help us kind of overcome the central limitation of biopsy and sampling error. Having identified this unique and specific set of tissue biomarkers in CS, our next steps are twofold: translating this discovery into something clinically useful, and in parallel, performing deeper mechanistic studies. On the translational side, we're actively working to make these tissue biomarkers into something clinically deployable. The Geomics platform is a powerful tool, but it's really not designed for clinical workflows. It's expensive, it's labor intensive, it's complicated, and it's quite slow. However, with only 7 biomarkers to profile, there are alternative options for clinical deployment. Thanks to recent funding from the Foundation for Sarcoidosis Research, we are currently developing faster, cheaper, and easier quantitative immunofluorescence pipelines to test whether these biomarkers will have a future as a diagnostic tool for CS patients. At the same time, we want to push deeper into the biology of CS itself. Deeper mechanistic studies, both in vitro and in animal models, are warranted to learn more about the specific cell types and cell states we highlighted in this presentation. Things like exhausted T cells, regulatory T cells, cytal-3 positive macrophages, and the relative absence of CD163 positive macrophages. Each of these really merit further studies so we can learn more about CS progression and identify new opportunities to interrupt that progression. I hope that researchers in the audience today are as eager to tackle some of these challenges as I am, and I hope to have a chance to work with some of you in the future as we try to do so. So with that, and with this sort of final picture of the earliest phases of our multi-marker IF panel development, I'm going to wrap things up and thank you all for your attention. I'm sure David, Birnie, and the rest of the committee here can share my email address if there are any questions. I'd be happy to engage with any of you who are in attendance. Thanks for your attention.
Well, what a wonderful presentation and very exciting research. I mean, I'm very impressed by some of the data that was presented there and look forward to more from Eliot. And so we're right on time and right on track. And so it gives me great pleasure to introduce the next speaker, who happens to be none other than Dr. David Birnie. David, of course, needs very little introduction to most of us. He is a staff electrophysiologist at the University of Ottawa Heart Institute and current.
So let's jump into the cases. So it's a patient that we saw. It's a 66-year-old female from Chinese descendants, and she works in finances. She was initially seen in our emergency department in May 2017 with a history of 3 episodes of lightheadedness and blurry vision and flushing with no triggers happening within 24 hours. While she was assessed, she had 1 episode of 6 beats of non-sustained VT on her telemonitoring. She had no chest pain, dyspnea, or completely loss of consciousness. No significant past medical history or family history, and her physical examination and vitals were normal, except for an elevated GVP. Initially, biomarkers were negative, and it was decided that she should be admitted for expedited workup. Her ECG on presentation showed sinus rhythm with right axis deviation and just non-specific ST changes. She had an echo done that showed mildly reduced ejection fraction with abnormal GLS and global hypokinesis. And because of the presentation and the reduced EF, she went to a left heart cath that showed normal coronaries. So the final diagnosis at that time was non-ischemic cardiomyopathy, and she was started on bisoprolol and perindopril. And she was discharged for workup as an outpatient. Unfortunately, a few months later, she went back to the emergency with an episode of syncope with a prodrome of dizziness, lightheadedness, and she lost consciousness for a few seconds with immediate recovery. On the ECG, she had a first-degree AV block and a right bundle, a little bit different from prior ECG. And she was waiting for an MRI and exercise stress test as an outpatient. And so during the visit to the emergency on telemetry, it was picked up periods of AV dissociation. So she was again admitted and expedited tests were done. So she had initially a CT test that showed enlargement of lymph nodes in the chest. The echo, a repeat echo, showed that EF was stable at 48 and with global hypokinesis. But the difference is that now she had severe concentric left ventricular hypertrophy that wasn't seen on the first echo. So because of the lymph nodes were discovered, she went to biopsy. That the sample came back as negative. And she had also a cardiac MRI that showed EF in the 40s and global hypokinesis. But the pattern of the LGE was a diffuse subendocardial and also patchy nodular midwall involving most of the myocardial segments. And she had elevated T2 indicating edema or inflammation. A PET FDG was done, and it showed multifocal intense FDG activity in the myocardium. Because of the arrhythmia, prior arrhythmia, and all those results of those investigations, she had a CRTD implanted. And here's an example of the cardiac MRI for this patient that showed the pattern of LGE and the function. And I'm going to show you the next image of her FDG PET by the end of October, when she came with that presentation. So at that point, she was started on metoprolol, and there was another trial of biopsy to get a sample and make sure that we confirmed the diagnosis of sarcoidosis, but it wasn't possible to get the biopsy at that time because of the size of the lymph node. So she went home and was waiting for assessment while she had another episode of syncope. And then when she came and the device was interrogated, it showed a polymorphic VT and shock. So she was started treatment in early December 2017. She was diagnosed as cardiac sarcoidosis finally, and then she was started on treatment with prednisone, 30 milligrams to take about 3 months, and then repeat the PET to check for suppression. She was also increased her metoprolol and started Bezartan, and she was on risdiplam already. So she had a repeat PET after 3 months of treatment with steroids, and it was good suppression. It showed good suppression, and so there was a plan of tapering the prednisone as protocol, low tapering for the next 9 months. After she was tapered off prednisone, on one of her visits to the device check clinic on the follow-up, the device interrogation revealed 7 episodes of sustained VT treated with ATP, and she was asymptomatic. So a third FDG PET was ordered while she was off prednisone. And then it showed, again, disease activity in the muscle. So she was diagnosed as a relapse, and in April 2019, she was started on second-line treatment with methotrexate along with folic acid. And the plan was to be treated for at least 3 years. A repeat PET after 8 months of treatment with methotrexate showed complete suppression of the inflammation in the heart. And then after 3 years of treatment and 6 months after stopping the methotrexate, another FDG PET showed that the suppression was still present. So she was doing well with NYHA class 1, and the F was stable between 40 and 45. And this is just an example of the images along the course of her disease. The initial image of when the diagnosis was done. In the middle is when she had the relapse, and then the last image is the image after she was treated with methotrexate and was off methotrexate for more than 6 months. I would like to discuss briefly this article that was published recently by our team here from the Ottawa Heart Institute on durable remission of cardiac sarcoidosis following discontinuation of methotrexate. So prior research showed that after 1 year of steroid, approximately 1/3 of the patients did not relapse, but however, 2/3 relapsed after the discontinuation of therapy. So this was a single study center. It was a sub-study of the CHASM to focus on the assessment on response of discontinuation of methotrexate in chronic stable patients with cardiac sarcoidosis. On a quick overview, it was composed of 12 patients that had the treatment. The treatment lasts for 3 years at least. The patients should be clinically stable before medication discontinuation, and FDG was done 6 to 12 months after discontinuation of the treatment. And a patient was also followed with annual echo and ECGs. So this is a timeline of how patients were followed. So with initial treatment with methotrexate, the dose was about 15 milligrams weekly. It could be increased if tolerated. The time of stability or treatment was at least 3 years, and the discontinuation was done after that, and then a PET FDG. So 11 of the 12 patients maintained cardiac sarcoidosis remission after discontinuation of methotrexate. That represents a significantly better outcome than the discontinuation of corticosteroids in other studies. The follow-up PET scans were performed after the medication discontinuation and revealed various outcomes. We had only one patient, was the patient 12, with cardiac relapse, sarcoidosis relapse, and we had a few patients with extracardiac relapse, but clinically they were stable. So comparing with previous studies, the dramatically improved outcomes with methotrexate compared to prednisone suggests that the difference may be by the drug itself rather than the treatment duration alone, but the treatment duration might also contribute to this difference. So as you know, methotrexate has traditionally been used as a second-line therapy for inadequate treatment response or steroid-sparing medication. It's in the international guidelines that recommend this as the most in most cardiac sarcoidosis cases. And it was recently reported patients treated as a first-line methotrexate monotherapy by these and colleagues with good PET outcomes, and they were similar to prednisone therapy. So the clinical implications of this study showed that treatment with methotrexate had a high remission rate, better outcomes than prednisone, and also showed that serial PET scans can predict patients who may safely discontinue immunosuppression. Clinical findings are important, and this study requires validation in larger and more widespread population. And the conclusion is that this prospective study demonstrated that 3 years of methotrexate therapy is excellent, and patients with clinical stability can be safely discontinued after disease remission. And only one patient experienced cardiac relapse on the follow-up nearly 2 years after the discontinuation of the medication. Thank you.
That's wonderful, Edgar. Thank you very much for that case presentation and highlighting the methotrexate discontinuation strategy that you guys have used. So I think that concludes all the talks, but I think we do have some time, and hopefully we might need to go a little bit over time to go over some questions. And a great way to start off the Q&A is in the chat for you, Edgar, and maybe Dr. Birnie if needed. How was the 3-year determined as the cutoff for deciding when patients should go off chronic immunosuppression? Is there something magical about that time period?
Maybe I can answer that one, Don. You know, it purely was picked out of my head one night. I just picked 3 years as not as a number, and you're absolutely right. Maybe less, but remember, all of these patients had a initial follow-up PET scan 6 months after the methotrexate, showing that the inflammation was completely suppressed or gone. We've no way of telling whether it was gone at 6 months or just suppressed at 6 months, without just having stopped the methotrexate there and then. But we just picked 3 years as a number, and maybe going forward we'll move it to 2 years and see if we get the similar result.
And maybe a follow-up for you, David. What if they've failed methotrexate first and now you're on a 3rd or 4th line agent? Would you do the same after 3 years?
Yeah, we've just started to do that. You know, we've used more and more, like I'm sure most of the folks on the call use more and more infliximab, which works wonderfully well. But we've now started, as part of our protocol, to do exactly the same after 3 years of stability on infliximab. We stop it, we repeat the PET scan 6 months later, and so on and so forth. But it's going to take a little while till we accrue that data. And they may behave differently. You know, there may be something different about, you know, the methotrexate responders may be an important subset, and the methotrexate non-responders may behave completely differently. So we'll just have to wait and see.
And just before we leave this topic, David and Dr. De Silva, You did the 6 to 12 month PET post, but was there any further imaging or assessment, or was it just based on clinical reassessment?
So the follow-up after the PET done 6 to 12 months after discontinuation, if the patient was stable and the suppression was good, the patient they were followed with ECG and echo and clinically, and then some patients the patients who had devices would be checked for arrhythmia as well on the device monitoring, and then if they had any abnormality, a new PET would be repeated after that if needed. Otherwise, it was just echo, ECG, and clinical observation.
And and with the algorithm in the paper, I think something like 4 patients had a further PET scan further down the line, and none of them had relapsed cardiac. In fact, 2 of the 4 were actually extracardiac relapsers, and their follow-up PET showed that their extracardiac was now in remission as well. So. Very interesting. PET's telling us a lot about the disease.
Absolutely. So for those of you in the audience, please raise your hand or write down the questions in the chat. I'll ask Peter, going back to Peter, thanks for coming back. So I really enjoyed your talk, and I know that in the randomized portion of the study, those patients who had a normal ECG and no clinical history had a very low pickup rate of active or cardiac sarcoid. So I can't remember if you highlighted this or not, but does that mean that if patients with extracardiac sarcoid with a normal ECG and no worrisome history, that we shouldn't pursue advanced imaging and further testing for cardiac sarcoid?
I think that's what it means. Now, when I think about the data from the study in their entirety, in both arms, I think there's the possibility that we underdiagnosed cardiac sarcoidosis in the randomized arm, and I'll come back to that, and that we may have overdiagnosed cardiac sarcoidosis in the chart screen arm. But what I mean by that in particular is that we may have found evidence on advanced imaging because somebody had a concern and pursued advanced imaging, and it was concluded that the patient had cardiac sarcoidosis. And that may or may not have been correct. Probably it was correct. There might have been some false positives, but the clinical significance of those imaging findings may not be entirely clear. So, what is clinically significant cardiac sarcoidosis versus not? I mean, we know from autopsy studies, as I mentioned, and as others, I think, have pointed out, like Dr. Cooper early in the day, that on autopsy we find granulomas in a much higher proportion of patients than was ever in whom there was ever evidence of any kind of cardiac problem before death. They may have died of an unrelated cause or of their pulmonary disease, but I think the line between what is clinically significant and what's not clinically significant, there may be some blurriness there in terms of figuring out during the course of one's disease whether there was something that was cardiac related, but certainly not something like sudden death or progressive heart failure. But we may have underdiagnosed cardiac sarcoidosis in the randomized arm. But I think that it's not like, this is a pragmatic trial in a sense, because we didn't have a protocol-driven diagnostic algorithm. This was based on the expertise of people with a lot of experience, who certainly are fallible, but I think that it's pretty likely that we're not missing cardiac sarcoidosis if we don't pick up something that triggers concern based on the history or the ECG. And it's fairly likely if we find something that makes us, at least if an expert in the area finds something on that initial evaluation that's concerning. And I would add that some of these folks came to us having had perhaps an echocardiogram in the past that also could have raised concern. So it's not necessarily just the history. They couldn't have had an MR or a PET because that would have excluded them from the trial. But if there was something, maybe they had lower extremity edema, then the proportion in which we find something ultimately consistent with cardiac sarcoidosis, 21% is pretty significant. that's a high number needed to find in any kind of a screening scenario, right?
Oh, true enough. David, I think you had your hand up transiently. I don't know.
Yeah, I don't know if it's my turn to ask a question, but I'm going to ask Juan a question. Fabulous presentation, fabulous contribution. A few years ago, I thought about maybe trying to make a cardiac sarcoidosis quality of life tool myself, and then looking at the methodology, I realized now, thank goodness I didn't, because I had no idea what I was doing. There's so much methodology to do these things properly. My question though relates to, as a clinician, I find that probably the two things that affect quality of life more than anything else in cardiac sarcoidosis is steroids, number one, but also number two is shocks from the defibrillator. And I just wondered, especially the latter, how are you going to factor shocks from the defibrillator into your quality of life score?
That's a great question. First, I will start saying that in any training when I've been doing learning about patient-reported outcomes, they always say if you can avoid it, trying to adapt an existing questionnaire, don't create a new one. So I empathize with what you're saying of not creating a new questionnaire for cardiac sarcoidosis is very challenging. And because we don't have these endpoints, we're still debating about how are we going to be screening, how are we going to be managing patients on treatment. Is challenging to make the new tool for quality of life responsive to pick up these changes. Like you want to know as a clinician, how are we going to factor this fear of a shock? What I have done is been supported by the PPI group and the patients living with the condition and how they want to being asked these questions regularly. So there are questions about, are you worried about your device, or how many emergency appointments have you had into your care? Have you attended emergency clinic? Have you been contacted by your team? So there are different questions that we'll ask, or trying to find out these questions and capture if there are concerns about a device or fear about the medication or the side effects. So there's still the waiting into how this is going to come into a total score. That's not, I'm still working to refine the final scoring of the new tool. But if we go into developing a tool, most of the good tools have different super scores rather than having a single score. Because if you have just a total score, you may miss a lot of the granularity that you can gain by having maybe looking into symptoms, function, social aspects, or maybe those related to the healthcare or the medication or the device, like we are debating now. So perhaps the final version of the questionnaire will have different super scores, which as clinicians in the day that you're coming with a patient, or the patient's completing the questionnaire at home randomly because they feel something has changed, this super score will give us important details to flag these concerns, rather than having a minimal change on the total score, then you don't know what that really means if you don't have that kind of detail on the super scores.
Yeah, David, as a follow-up, like I find the phenotypes of these patients to be very different, right? You'll have extremes of VT predominant patients, advanced heart failure patients, patients who don't need treatment. And so you're going to have a varied, I guess, health-related quality of life or patient-reported outcomes depending on the phenotype. And I'm not sure how you can weigh the different phenotypic presentation with the scores.
Yeah, that's a great point. And I think when I put it on my reflections at the end of the slides, on my final slides, in terms of what would be the best combination, and exactly what you define in terms of maybe for patients that present with heart failure, we need to combine the CARD-SARC with a heart failure questionnaire and help to narrow down those specific points and combining the two questionnaires rather than just relying on a single score. And maybe for those that are having arrhythmias, maybe is a different combination. Maybe when you have more than different organ involvement, the King Sarcoidosis questionnaire includes different fields for lungs, medication, skin, and eyes. Maybe we need to, as a community, put together more data and trying to get into all the centers that have been collecting data for the different questionnaires. How can we narrow it down, as we are trying to do, when to stop doing a PET scan for every patient every 3 months. It's very tempting, but it's a risk of radiation, isn't it? We don't want to overwhelm patients by saying you need to complete the questionnaire or 7 questionnaires every 3 months. But how do we tailor the best combination? That's something that we need more data in order to make that final decision.
Yeah, I know it's a tough one to do, because it's also the different phenotypes, as Mustafa says, is so important, but it's also such a dynamic disease. When I get a new diagnosis, the patient's quality of life is pretty good when I first see them, and then I start treating them, and their quality of life goes downhill, and then they have VT, and it goes down even further. But you might, I don't know if you've got an EP or arrhythmia doctor on your steering committee, because there's actually a fair bit of work on shock anxiety score. There's actually a shock anxiety score. I don't know if you're familiar with it, but you might want to bring in some elements of shock anxiety. It's the Florida shock anxiety score, something like that. You might want to bring in elements of that. I don't know if you can do that.
Yeah, that's a great suggestion, David. And the initial pilot version included the hats to measure for anxiety, that we can look into tailoring a bit more, refining, because the initial work was including only 2 centers in England, and now we need to get more data internationally, and we'll have to validate this with larger cohorts of patients and people living with cardiac sarcoidosis.
If you need any centers, I'm sure the Canadian centers would be happy to help you with.
I'll take this opportunity now, and I will contact everyone.
That's good. David, can I ask you a question, which is, one of the things that I find somewhat confusing out there is nomenclature, and there is a lack of defined nomenclature for, definite, probable, possible, all that stuff. Do you think the new HRS document is going to help resolve that?
We that's an excellent point. We did listen to that feedback, and we've tried to do that, Mustafa. One of the things we've done is we've actually defined, for the first time, we've defined metabolically active and inactive disease. We've also clearly defined clinically manifest and also subclinical disease. There are specific definitions for that, but we're still left with the definite and probable, but they're very precisely defined now, the definite and the probable. That comes from Peter will tell us, that comes from the sarcoidosis literature. They can never be, they have definite probable for the diagnosis of sarcoidosis, so it comes from that. So I think it's better, but is it perfect? Probably not. We have to wait for Eliot's test. If Eliot's biopsy test really comes to fruition, that you can biopsy the heart anywhere and get a diagnosis or exclude the diagnosis, my goodness, what a game changer that's going to be.
Yeah, it's too bad he's not here to ask him this question, but when he talked about the remote, it was only a millimeter away. I think it's whereas. What if you're 3 centimeters away or 4 or on the opposite side of the LV? Is that still going to be considered remote? That's what I wasn't clear on.
Yeah, my understanding, I've seen him present before, was you can still be quite, you can be centimeters away and still have quite abnormal proteomics. So it's going to be fascinating watching how that develops. We're going to have to finish after one more question because the next session started at 1:45. So Peter?
Yeah, I'm really sorry Eliot isn't with us live, because I had a question for him, but it pertains exactly to what we're talking about. And, he mentioned that they had a diverse array of non-sarcoid cardiac disease among his quote-unquote controls. But I think the appropriate controls would not necessarily be the entire array of cardiac disease, but most particularly inflammatory cardiomyopathies, such as Leslie Cooper talked about in the morning, where in practice there's diagnostic uncertainty, because for some other conditions there really isn't a question about sarcoid versus the other disease. So in order to understand more about the sensitivity and specificity of these new powerful and elegant proteomic and transcriptomic assessments, we need to have good controls. And then while in an experimental setting where you have a biopsy that shows a granuloma and the perigranuloma or the more remote from the granuloma signatures, in practice, if you biopsy the heart and you don't see a granuloma, you have no idea how far away you are. And where you are in relation to the granuloma will probably have a major effect on sensitivity and specificity and all of these things. But I totally agree with the idea that this is a direction that the field needs to go in terms of understanding better how we can make use of diagnostic tools and, state-of-the-art technology and techniques for assessing genomic and proteomic signatures in their relation to how we can make a diagnosis clinically. Yeah. So I'm sorry he wasn't able to participate in this discussion because that was a beautiful data set and there's so many questions. I mean, like any good research, the information raises new questions, and the more questions, the more important the research usually is. So anyway, and thank you guys. I really appreciated this.
And with that, I think we'll close off the session. We appreciate all the speakers. Thank you very much for your time and commitment, and to the audience members.